I decided to make this presentation, like we had a patient with who had Lyme's disease, and she was in doubt, the patient, that if her actual symptoms were related to Lyme disease. Then we discussed like the acute phase and many times the long-term symptoms related to infectious disease. And then we made the correlation with COVID. So that's what inspired me to make this presentation related to the new condition that is the long COVID term. So my name is, I am Dr. Renan Francisco Oliva. I am a neurologist doctor from Brazil. And the objective of this presentation is to discuss the neurological findings in the acute phase of COVID and the long-term sequela and effects of COVID. So here's the summarized clinical case. We saw a female patient. She was 19. She was complaining of chronic anxiety. She works as a radiology technician, and she said to us that she had Lyme's disease at the past, and she was in doubt if her actual symptoms were due to a psychiatric condition or related to Lyme's. She has an important history, family history of psychiatric conditions. Like she said that her mother has bipolar disorder and the father obsessive compulsive disorder. And the main complaints were persistent anxiety, fatigue, arthralgias, difficult to think and concentrate. And she was very worried about these things because they were like disturbing her life and her general activities. She mentioned that she felt overwhelmed by having to take care not only about the family's disease, but many family issues. And she already has gone to many different doctors, and most of them said that the symptoms were just related to anxiety. And after she told Dr. Bernard that she suspects or she's worried that these symptoms would be related to Lyme disease complications. So I use some articles to make this presentation. These are the ones, my references. So talking about COVID, the real problem with COVID is that it's a new virus. The first reports began at the end of 2019. So the main problem is that we don't know much about, we didn't know much about the effects and the consequence of the virus. And nowadays, even though we already know many things about the acute phase related to long-term complications or even sequelae, we still don't have many options to treat, or we don't know the prognosis, the long-term prognosis related to COVID. So that's when this new term, that is the long COVID, came. It's related to the long-term damage and sequela related to after the acute phase of COVID infection. So the main problem is to see the actual scenario where we stand on. Then we know many things about the acute aspects of the infection versus the long-term consequences of the COVID. So here is an extract from one of the articles. So as we know, the COVID is a new virus. It's a RNA virus. And like in most of the cases, it produces mild or even asymptomatic cases. but it has a high rate of transmission and damage to the patient. It's a virus that's encoded with a surface envelope, and the article says the exact dynamics of SARS-CoV are currently unknown. It supposed to be like a mixed virus from animal origin that started in China and like a human variant. So like it would be antigenic shift of virus. So like I said, regarding, I used to say to the patients also, all the recent discoveries are very new, and even its long-term burden. This presentation should make an analogy to Lyme's disease, because on Lyme disease, we know that there are many acute phase symptoms, and even when the infection is treated with antibiotics in the case of Lyme's disease, there are many long-term sequelae, mainly involving the heart or the central nervous system, or persistent arthralgias, or fatigue, or polyneuropathy related to Lyme's. So in this way, it's the rationale about these two diseases come to be very similar. And I used to tell my patients that after the lung, the main organ that is involved, it would be the central nervous system. And one of the difficulties also is to distinguish, to differentiate the long-term complications related to COVID to those of other diseases, mainly like neurodegenerative diseases, epilepsy, psychiatric disorders, like we saw in that patient. Like she was confused. She didn't know if the symptoms were related to Lyme, or they could be justified by another disorder. And so we have the many emotional symptoms like anxiety, difficulty to concentrate, insomnia, and depressive symptoms. Like it's the question is, are they isolated symptoms, or they are like a consequence or a cause related to COVID? So what we know about the COVID virus is that's a neurotropic virus, like for example, the herpes virus. So what was discovered that it uses the angiotensin type 2 receptors. So it has the potential to affect many organs of the human body, such as the reticuloendothelial system, the heart, the lungs, and the central nervous systems, and the peripheral nerves. So in the central nervous system, virtually almost all of the cells have the potential to be affected, like the neurons, the astrocytes, the oligodendrocytes, and like there is this coding to the receptor, and also there is the arrival of the virus by the bloodstream to the central nervous system and by the olfactory fibers, in analogy to other infectious diseases like the herpes virus. So here's like a figure, like describing many places that the virus would infect. Like there are, at the right, there are the neural cells, like the neurons, the astrocytes, and in this location there are the blood-brain barrier. And below that, there is the representative of the virus, and it's capable to attach to the angiotensin converting receptors, and then to uncoat and then enter the cell, infect those cells, and after promote infection. And in this figure to the left, there are the bloodstream transmission, like and also the olfactory tract fibers transmission, like the it reaches the central nervous system by the olfactory bulb, and then it has the potential to affect not only the cells, but many different regions of the central nervous system, like the cingulate gyrus, the motor cortex, the temporal regions. So that would justify many of the symptoms because of these anatomical locations related to the virus infection. Along the direct coding and infection of the virus, there is also an exaggerated inflammatory response. So the immune system responds with like a very exaggerated inflammatory response when the immune cells are attracted to the. I would have to interrupt, like I continue. Can I continue?
Yeah.
Yeah. So like there is an exaggerated inflammatory response when the immune cells like produce damage as they recognize this infection and the neural cells that are infected with the virus, and that not only produces the acute phase symptoms, but also has long-term consequences, these post-inflammatory state that is generated related to the COVID. So here is another picture, like the virus, once it's attached to the receptors, has the potential to infect many organs of the body. So the central nervous system, the lung, the heart, the reticuloendothelial system, not only by direct infection, but also by the immune mediating injury. So that justifies many of the symptoms in the acute scenario, like the hypercoagulability state that has the potential to produce pulmonary embolism, ischemic stroke. In the central nervous system, the core symptoms would be like headache, dizziness, seizures, and even Parkinsonism. In the peripheral nervous system, there are muscular damage, and neuropathic pain, dysfunction of the olfactory and the gustative sensations, and even autonomic manifestations like oscillations of the blood pressure and dysautonomy symptoms. And in the more severe cases, like there is the well-known acute respiratory distress syndrome related to the virus in the lungs, the effects on the heart, mainly arrhythmias or like ischemic phenomena related to the heart, renal damage with renal failure, along with many times severe central nervous system manifestations, such as stroke, such as cerebral edema, persistent cerebral inflammation. So as I said, the main symptoms in the acute phase would be like a malaise, cough, fever, dyspnea, loss of smell and taste, nausea, dizziness. But many patients are, as we know, as we had seen in the 2020 and 2021, many patients can be asymptomatic or very, very mild general symptoms. And even in these cases, they are at risk for long-term, for the long COVID syndrome. So along with the mild cases, the general manifestations, there is a risk related to the more severe acute neurological manifestations, such as thrombosis, stroke, encephalitis, an intense cerebral edema, and also in the peripheral nervous systems, such as inducing Guillain-Barré syndrome after the stimulation due to the virus, polyneuropathy, transverse myelitis, and what we saw in many cases, rhabdomyolysis, due to the direct infection of the virus on the muscles and the intense destruction that occur in the muscles and then leading to renal failure. In the acute scenario, like we have many different diagnoses, like even if there is an infection of COVID going on, we know that many patients, and usually are the more severe cases, have a very high risk cardiovascular profile, like they were obese, or they have diabetes, or they smoke, or they were like elderly person. In this scenario, many times it's difficult to see if it has a correlation with COVID, or if the conditions would be superimposed by stroke, by another kind of encephalitis, or in the previous epileptic patients, they would get worsening of the seizure because of the acute distress, and then we need to differentiate what was the worsening of epilepsy or the main COVID effect. And its association with other organ damage like the lungs, the heart, as I said, the kidneys, and its tendency towards the thromboembolic phenomena. So here is another extract from the articles. Like, we know that there is a tendency to the hypercoagulability, and once the virus has uncoated and infected many cells, like there is an exaggerated immune response, not only in the central nervous system, but in the whole body as a whole. So we saw many of the little effects were related to this aggressive immune response to the virus. So here are some like justifying the long-term effects related to COVID. What we saw in neuroimaging, like there was in many cases was an enhancement of the meninges, in cases where there were like meningoencephalitis, there were signal changes in the upper pons, the limbic region, not only justifying in many cases the disturbance on the level of conscience, but also in the long term the psychiatric manifestations like anxiety and depression because of the damage and inflammation in the limbic system. And even long-term seizures, like we know always when there is a damage or a lesion to the temporal regions, there is a high risk of not only psychiatric symptoms, but also epilepsy at the long term. Also lesions to the thalamus, to the subcortical cerebral white matter that would justify the cognitive dysfunction at the long term. It was also seen lesions in the extrapyramidal system, maybe justifying the extrapyramidal symptoms in the acute phase. And then the virus has the potential to induce in many different cerebral regions, many different focus of inflammation and infection. So that would justify the cognitive and psychiatric long-term effects, as well as thromboembolic phenomena also in the central nervous system, when we saw many cases of stroke or venous thrombosis related to the virus. And then this exaggerated immune response would induce swelling of the brain, thus aggravating the duration of the disease in the acute scenario, and also impose the risk of even brain death related to this intense brain swelling. So here are some from one of the articles, the patterns of the image. Like we can see many different locations of inflammation, and even with established brain death, like a reduction in brain size, inflammation, intense cerebral edema, in stroke events, and here the multiple focus of microbleedings along the central nervous system. So again, like after the acute phase, like we have many questions and challenges, like what would be the long-term impact related to COVID, how the patients would recover. And the patients always ask, like, oh, I have these psychiatric symptoms, I am feeling anxious, I'm feeling, I am having problems with my memory, to reason, to solve problems. And what could be done? Like, what medications could I take? Or is there something that could be offered? And for how long the symptoms would last? Like, how, what would be the time for recovery? So in the patients, I've heard many times, like, I'm going to be like this with these difficulties that I didn't have for how long time. Will I progress to dementia or permanent damage? How can you differentiate, like, in that patient with Lyme's, if it is related, like, many months after, if it is related to the infection, or it's a psychiatric condition that is unrelated, or if there are both things, one aggravating the other. So the articles were, in fact, all of the articles that I researched and studied, that like at 6-month follow-up after the acute scenario, there were many persistent symptoms, like sensation of fatigue, like in 34% of the patients, difficulties in memory and attention span in 31%, and insomnia, like these, like, as well as what we are seeing, the practical scenario with the patients were the most frequent complaints. So it's very common that a patient that has had COVID comes and complains, or even makes an appointment with a neurologist, complaining of fatigue, with problems with memory, attention. And like even the acute symptoms were persistent, like the hyposmia and the cognitive deficits that we saw in the acute phase persisted for a long term, many times months or even 1 year after the patient recovered from the acute phase. And like as we are seeing, the difficulties in memory, the real cognitive disturbance is very common. It's very, like, reportable from the patients, like leading to many difficulties in the daily life, in many cases, disability to work or emotional problems. So we have like after the majority of the cases of COVID, we have an immense social burden that we not only must face, but like try to research and try to discover solutions and how we would manage these patients. So here's like a diagram, like putting the long-term manifestations, like I said, the concentration complaints, fatigue, sleep disorders. And as we can see, even in asymptomatic and mild cases, these complaints have been observed. Like not only as we could like figure, not only relate to severe case or patients that needed the ICU or complex hospital care, but many patients, many times they even didn't have symptoms, and there are these consequences of brain inflammation, the brain recovery post infection by the COVID. So as we can see in this picture, like there is that we used to call the mild, the moderate, and severe, and we can see statistically like there are many cases, even the mild scenario, like with persistent fatigue, psychiatric conditions, depressive symptoms, anxiety, and like general weakness, fatigue, and And here we can see also the difficulties in an independent life, in the routine daily activities, and like many issues relate to emotional and work problems. So, like I said, according to the articles, the most prevalent symptoms were the fatigue, the memory complaints, the sleep disorders, and most the psychiatric symptoms. So I found it really interesting to make an analogy to well-known infectious disease that would behave like the same way, like we saw in that patient with Lyme's and post-herpes virus infection, when we have the acute scenario and then the long-term consequences. And like it said here in the study, long-term neurological complaints show different distributions according to COVID's severity. So in all groups, they observed like many persistent symptoms. The cognitive impairments is a very important aspect. Like I said, not only due to the burden, the social and the emotional burden, but we can see in the office, like when we test with the Montreal Cognitive Assessment or more specialized neuropsychological evaluations, that many patients really have difficulties to concentrate, to remember things, and that implies a reduction in the work performance and aggregates emotional disturbance to the patients. And then there are the statistics then demonstrate that during the acute illness, common cognitive problems include confusion that, as I said, persisted in the long term, difficulties in concentration or attention. So not only it would be like a delirium state, but it would have the risk of inducing long-term sequelae. The studies find, as I said, they intend to involve multiple organ systems, including the peripheral and central nervous system. And these were related to the persistent and intense inflammation and the general symptoms, like I said, not only in the acute phase, but predominant and prominent in the long term. So, as I said, many questions in the office or like when you see the patients after, when you evaluate them, how long the symptoms will last, what could be done, are there any medications that I could use to get the symptoms improved, what therapies should be done, what would be the general evidence for these therapies that could be applied to my case. What I do if it doesn't get better, like should I stop working, should I go retiring, or what can I do with these difficulties that are generate problems with me and my family? Will I progress to dementia? For how long it will last? Is these symptoms common, or like that patient with Lyme said, is this real, or is just my impression? And if it's just my impression, what could be done? So we can see that the patients have many doubts and many insecurities related to the disease. So the Nature published a large study with a large cohort study, like seeing at the long term, 1 year after the acute phase, with many veterans, not only the acute phase, but the long-term effects of COVID in a large series of patients. So here's like a diagram from the studies, so we can see, like I used to say to the patients, the COVID not only relate to the virus, but also the inflammation and the predisposing to thromboembolic effects. like it imposes a risk to cerebrovascular disorders, to cognitive impairment, to the peripheral nervous system. It worsens the patient that already has migraine or epilepsy. It can impose the risk for extrapyramidal symptoms to many psychiatric disorders, mainly depressive anxiety symptoms, the musculoskeletal, the sensory manifestations. So virtually, as we can see, not just in the acute phase, but related to the long COVID syndrome, virtually every structure of the nervous system would be affected and has the potential to be affected, and with symptoms related to the COVID. So the articles, mainly the Nature one, emphasize the burden of mental health disorders. So like there were many associations, like if the patient already had a psychiatric disorder, that would worsen, and the patient that doesn't have a psychiatric disorder, it would impose a risk for depressive disorders, to post-traumatic disorder, to adjustment disorders, and even psychotic states related to the infection and the damage related to COVID. And in a statistical significance in a large sample of patients. So the conclusion of the articles is what we are going to do in the long term. Like the article says that the governance, the health system should take into account the findings that SARS-CoV leads to long-term and other serious consequences, and how we should design policies and how we should adapt to these long-term effects. And maybe they even says that it would be a long-term or even worse, a lifetime effect related to the infection. So that would have profound ramifications, not only on patients' quality of life, as I said, and in general life expectancy, but in the raising the costs of the health system in all of the countries over the world, and the burden, like these people have difficulties, or many times, depending on the profession that they use to work, they won't work anymore. So there's also the economic burden, and the raising the costs of the public health system, or the health system as a rule. And the unfortunate part is that we don't know how the patients will recover, and how it's going to be, for how long. So we have all these our generation, and even the new doctors after this pandemic have this challenge of dealing with these patients, to follow them, and to research possible therapies related to all this burden. So the conclusion one is that of the articles, that the findings include that several neurological features are a relevant component, as I said, they are vulnerable, and the patients that had a severe case would be more predisposed to that, but also occurring in mild to asymptomatic cases. So there should be longitudinal programs to track the real impact of SARS-CoV infection on long-term brain health status, and as well as the clinical complaints and manifestations in the follow-up of the patients. So as a conclusion, it's like I said, it's a recent virus. Till 2019, we didn't even imagine. I used to tell the patients, we didn't even imagine that what a virus would be produced such a burden and such damage to the society, to the patient, leading to many deaths and many sequelae. Like there was for many months, there was like we say, a company of, unfortunately, by many people, by denying the problems and saying that was just a common virus, that the World Health Organization used to be, they were exaggerating, and now we are seeing that the situation is even worse that we once thought. Then it appeared a new entity, like after the pandemic improved, like what was to be the long COVID syndrome that includes all these burden, these symptoms of, like I said, the cognitive disturbances, the sequela, the fatigue, the many times arthralgias or myalgias that like they are considered as sequela, and it's a long-term entity separated from the acute phase of the COVID. For now, it's difficult to the medical community as well as the health systems to estimate the long-term effects and for how long, and what strategies we could use to mitigate or to control these manifestations. It's very important, the follow-up of the patients should be attentive to differential diagnosis. Like I said, in that case, like the patient with Lyme, if the symptoms are related to both conditions, if one aggravates the other, or if the new psychiatric symptoms like the difficulty in concentrate, the post-traumatic disorder, the anxiety, the depression, or the psychotic states would be like justified by the infection of the COVID. So we have to search for new answers in the long-term following of the patients. So like I used to tell the patients that unfortunately just in the long term and by following them, that many questions that we have may be like answered as the studies goes, and like when we gain more experience in dealing with this case. And another question is, should we try empirical treatments? Like if a patient has difficulties in attention, should we try neurostimulants? Because we, like at the moment, we don't have much evidence to see if these treatments would work or it would be beneficial. So many strategies are at this moment are off-label and based on clinical judgment. And the exact role of rehabilitation, like the physiotherapy, the psychotherapy, and what these patients would improve with these therapies. And always consider the burden, the social burden, and the burden to the healthcare system and the social aspects in a whole view of the patient. So that will be it.
Okay. Are you done?
Mm-hmm.
Okay, thank you. Okay, hang on here.